It's always tough to be between an audience and cocktails. And that is what's next on the program. But I think you'll find this interesting. You know, from the employer's perspective, and you know what, we need the slide changer up here. Thank you very much. How did you get it, Anita? Really? Thank you. Okay. From the employer's perspective, there are two primary manifestations of poor workforce health: healthcare costs and lost time from work. The healthcare cost issue is well known and certainly well documented by employers. It hits the employer's bottom line in a nice, tidy, albeit unwelcome package each year. The impact of lost work time typically isn't as clear. Work absence often is found in separate program silos: sick leave, PTO, salary continuance, family medical leave, short-term disability, long-term disability, workers' comp disability, often managed in various parts of the organization and often poorly tracked by employers. Lost time associated with reductions in worker performance related to health, so-called presenteeism, is typically less visible and certainly harder to measure. Yet a variety of research studies, both by IBI and other leading researchers, tells us that the cost of wage replacements and lost productivity around absence is at least as large as healthcare costs in its impact to the employer's bottom line. Now, today we'll focus our attention on the more tangible aspects of lost work time, and that's absence. We'll break down some of those silos, take a more integrated view of absence, and explore opportunities for interventions and improvements. And we'll do this through new IBI research that actually we released today. You have a copy or have access to a copy out front. There it is. Please pick up a copy before you leave. The research examines the links between family medical leave, short-term disability, and long-term disability. Now, we address a fundamental question in this broader discussion and broader approach to absence and its management. Can family and medical leave be used as an early warning system to prevent and to ameliorate the impact of longer disabilities and their absences? That is this stuff connected together? Presenting the findings of this new work is IBI's Senior Research Associate, Dr. Brian Gifford. Brian served as the principal investigator for this research. But before I turn it over to Brian, let me just highlight some of the key findings of the research. First of all, family and medical leave does impact short-term disability experience, both through incidence and through durations. Second, employees who are ineligible for FML may still benefit from interventions. Third, when employees don't have access to STD benefits, claims for continuous family and medical leave absences are longer. Fourth, STD durations are 6 to 9 days longer when preceded by continuous FML claims. And finally, FML leaves also can be an early warning system to long-term disability claims. So we see FML playing a critical role in what happens later. Now let me just give you a couple of minutes on the study itself. And it's important to understand that this study looked at employees over 5 years. Much of the research done on this and health and productivity topics looks at employees in a single year and looks at across employees. This study of about 520,000 employees in 160 different employers, looked at their experience over a 5-year period from 2007 to 2011. So the longitudinal aspects allows us to actually track individuals and how they access these different systems. A very important study design issue. Now, the key research questions: do FMLA users have different patterns of FTD and LTD use than non-users of FML? For STD claimants, is early use of FML a predictor of disability duration? What characteristics of an STD claim are predictive of later LTD claims? And is there a Friday, Monday pattern of intermittent FML use? So these are the questions that really frame the research that Brian undertook. When Brian finishes his remarks, we'll hear from a panel of experts. Maria Henderson, Senior Director, Workforce Health at Pacific Gas and Electric, right in our backyard in San Francisco. Anita Weir, Director, Medical and Disability Management, Corporate Risk at Safeway. And we asked Anita to speak because the corporate risk perspective becomes really critical to this broader conversation. Cheryl Jez, Regional Practice Leader, Reliance Standard Matrix. And Denise Fleury, Senior Consultant at Mercer-Trion. So Brian will go through rather quickly the results of the research. We really want to spend the time with our panel. So I'll turn it over to Dr. Gifford.
Good. Thank you. First of all, let's just go through a quick refresher on the types of leave programs that I'm going to be talking about today. Of course, the Federal Family Medical Leave Act, it provides employees with up to 12 weeks of unpaid job-protected time off for a serious medical condition, either their own or a medical condition of a close family member. This time can be taken off continuously, so all 12 weeks in one block, maybe a shorter duration, 3 weeks in one block. It can also be taken intermittently, which is to say a day here, a day there, in order to make therapeutic appointments, in order to deal with issues as they come up on an as-needed basis. Right now, perhaps 60% of the workforce is covered by this program. You have to meet certain criteria, such as working for an employer for about a year, at least half-time, and there have to be at least 50 employees within 75 miles of the work site. By contrast, short-term disability, long-term disability, of course, are paid programs. Basically, eligibility is, for most employees, if your employer offers it and you accept it, you're eligible. There are some states that have disability programs, for example, New York, California, but mostly we're talking about the short-term disability programs that employers offer. And of course, the benefits that are offered, the duration that are offered, these are set by the plan rather than by law. Now, anyone who has spoken with employers about FMLA, or if you are familiar with a very recent report from the Department of Labor surveying employers, you understand that workplaces continue to face difficulties with different aspects of the policy. And so there are difficulties with the process of certifying that somebody has a serious medical condition that qualifies for FMLA. There are difficulties with tracking time off, especially intermittent leave time off. But especially, and for our purposes, there are difficulties with managing the disruptions of absences when they occur. Whether they be long absences, of course it's disruptive when somebody's going to be out for a week or a month or certainly 12 weeks, but also unscheduled intermittent absence. And when we talk to employers, we've heard repeatedly that this is one of the most challenging aspects of managing absence. And it's probably not too much of an exaggeration to say that after 20 years of the law, many employers are experiencing what you could call FMLA fatigue. Now, these challenges notwithstanding, as Tom said, the findings I'm going to be taking you through today, they shine a light on a different aspect of FMLA, and that's as an early warning system. Because when you think about it, when somebody is invoking FMLA or when somebody is bringing a serious medical condition for the purposes of getting job-protected time off, this is going to be one of the few times when an employee is formally making known that they have a problem to an employer before a disability emerges. And this would be the time, we would argue, that you would want to start connecting them and engaging them with available health and wellness programs, disease management, health promotion programs, and so on, solely, or well, not solely, but in some respects to avoid costly or future disabilities. And so as the schematic up here will show, you can always think about this in terms of early action is going to be better. It's like when you're repairing your house or your car, it almost never gets cheaper to wait. There are going to be multiple opportunities to engage employees in their own health, and every missed opportunity, of course, is potentially higher expenses down the road for the employer. Now, just for a quick overview of the data that we worked with, we found that in this sample, 1 in 5, or over 5 years of observation, 1 in 4 employees had a Family Medical Leave Act, so about 5% a year, if you annualize it. And about 1 in 7 had a short-term disability claim, maybe 3% per year annualized. Most people who used FMLA used it continuously, but 1 in 3 used it on an intermittent basis. So this is a good news, bad news story, because again, when we hear about the difficulties people have, we tend to hear about intermittent leave. So on the one hand, over 5 years, you'll have maybe 7% of the population using intermittent FMLA leave. So we start to think of this as the problems or the difficulties that people face are more qualitative than quantitative, perhaps. But again, this also means that 1 in 3 FMLA leaves are for intermittent leave. Okay, so it's certainly non-trivial when you start to focus in on the people who are actually using their entitlement. Very few people use long-term disability, but just remember, of course, that you have to go through short-term disability first. Oh, and we found that we had 1 denied leave request for FMLA for every 6 leaves that were taken. These could be denials because the certification was done inappropriately. These could be people who had not met all of the eligibility criteria. They had not worked for 12 months, for example. This should not be read as that is the percentage of people who asked for leave but did not have a serious medical condition. Only about 1 in 4 of these people with a denial never got an approved leave. So the medical conditions were there. It comes down to getting them certified. Most of the people who used leave for any specific program, they only used it in 1 out of the 5 years. And these are new leaves. So a leave that started in 1 year, carried over to the next, would be considered 1 leave. And there are 2 important things about these particular findings. One is it shows that the 5-year results that I just showed you are mostly driven by different people. It's not the same 24% of people who are using FMLA. So it's not necessarily this small proportion of people that you're going to have to see using it again and again. And so you don't just focus on one set of people. But secondly, there are, let's say, 1/3 of people who use FMLA who are going to use it in more than 1 year. So just because a serious condition comes to light that actually gets to the point where it requires time off, it doesn't mean that it's too late in every case to start engaging people in their health and connecting them to different programs that a lot of employers already offer. There's still the possibility of mitigating future leaves of the same kind of program and of preventing leaves across programs. Now, just in terms of providing a full picture of how FMLA and short-term disability fit together in these data, we found some evidence that employees without access to short-term disability benefits will tend to use FMLA as a substitute, and this makes sense. Your need for, well, maybe it does, but your need for time off because of a serious medical condition isn't going to be 100% driven by who you work for. Okay, so workers whose employers didn't offer short-term disability benefits in our data, they average about 11 FMLA days over 5 years compared to about 8 days otherwise. Bear in mind, this includes a lot of people who use 0 days over 5 years, many people. But we've also adjusted for people who use short-term disability and FMLA concurrently, which the law allows. The law allows employers to start running off a person's entitlement for FMLA when they're using short-term disability or when they're out on sick leave for a longer term. So it's generally the case that in the employers that we saw that didn't have short-term disability coverage, we see more FMLA use. Now, I mentioned before some of the challenges employers face in dealing with intermittent leave. And one of the most frequent issues we hear is that some employees, and I stress some employees, will use intermittent leave as a way to give themselves a long weekend. So they will call in on a Monday or Friday and say, this has come up and I can't come to work today. And since they have a certification that says they can take time off on an as-needed basis, they're protected by law. Now, this gives rise to what I've heard of as a derisive nickname of FMLA as the Friday, Monday Leave Act. And because we had over 900,000 intermittent leave episodes to look at from multiple employers, we had an opportunity to assess the prevalence of this problem. And we looked at the data in a number of different ways. For example, we looked across industries. We looked at high-volume FMLA intermittent users by low-volume users. We looked at hourly employees compared to salaried employees, age, gender. The answers tended to be very similar, in fact, similar to what we're showing here. We didn't find any compelling evidence to suggest that intermittent leaves are more likely to be on a Monday or a Friday than on any other weekday, Saturday and Sunday, of course, let's count those as weekends, but generally close to what you would expect on a Thursday, a Wednesday, or Tuesday. We also didn't find any evidence that these kinds of intermittent leaves tended to be full-day absences, or were not more likely to be a full-day absence than a Tuesday, Wednesday, or Thursday, and in fact, they weren't even much longer. Now, this doesn't mean that some employees don't misuse their certifications for leave in this way. I'm certain that they do. It says nothing about unscheduled intermittent leave. We were not able to measure that in these data. And of course, it doesn't say anything about another complaint we hear about intermittent leave, is that the people will use this to circumvent absence and tardiness policies. What it does indicate is that to the extent that these things occur, and regardless of the headaches that they cause, and we realize these headaches are real, they're not the dominant pattern of intermittent leave taking. And so it's probably safer to say that the vast majority of the cases have a much higher potential for benefiting from wellness programs, for benefiting from disease management programs, and so on. And employers are going to have to decide for themselves how to balance their priorities against the people that they think are misusing the program and the people who could benefit from some of the other programs that they offer. Now, here's where we come to what I consider the heart of the analysis, which goes to this question of whether an observation that somebody has used FMLA indicates a higher than average likelihood of a later short-term disability claim. The answer very clearly is yes. It's generally the case that somebody who has used FMLA in 1 year has a higher than average likelihood of using FMLA or using short-term disability in the next year. And so in this example, we take a person, our baseline case. They had no FMLA leave in 1 year. They have about a 3% chance of a short-term disability for a physical health condition in the next year. So we're excluding pregnancy, short-term disability leaves here, and we're excluding the child bonding category of FMLA also in these results. They are in the model. They're just not shown here. Now, a person who had some kind of FMLA leave, their chance of short-term disability use in the next year goes up by anywhere from 40% to 100% of the baseline. Okay, and these results, they're adjusted for age, for sex, for organizational characteristics, for whether somebody was an hourly or salaried employee, and very importantly, for whether or not they used short-term disability in the previous year. And because the law, again, the law does allow people to take their leave concurrently. So you can think of these as, these are pure cases of FML for these purposes only. We also see that the type of leave matters. The type of FMLA leave matters. So for example, a leave taken for somebody's own health condition is more predictive of a physical claim, short-term disability, than leave taken for a family member's condition. But family member conditions, very important, they still do matter. A person who goes out on FMLA because they have to help a family member through some kind of serious medical condition has a higher chance of a short-term disability for a physical condition than somebody who doesn't use FMLA. And this could be because of the stress of taking care of an ill family member exacerbates a health condition. It may make it harder for people to focus on their own health to begin with, but there does seem to be a pattern here. And finally, people who are denied FMLA still have a higher than average likelihood of short-term disability in the next year. And so it bears repeating, just because an employee doesn't qualify for FMLA at the time they ask for it, it doesn't indicate that they do not have a serious medical condition. Okay, and it doesn't mean that by not taking unpaid time off, they won't end up taking paid time off later on. The results were similar when we looked at mental health claims. Generally, somebody who uses FML has a higher than average likelihood of a short-term disability claim for a mental health condition in the next year. I only want to point out further in this slide that relative to this baseline group, it looks like FMLA for family conditions is more predictive of mental health claims than of physical health claims. So here, if you just compare any of those groups to the baseline, you're getting to be about, the likelihood is about twice the baseline. It's about 50% greater for the physical health conditions. And this is exactly what we would expect if the stress of caring for a family member contributes to a person's need for disability leave. Intuitively, it just makes sense that stress-related problems are going to manifest and take the form of, say, anxiety or depression or fatigue or something like that than they would for somatic conditions. But again, they still do matter for physical conditions. And pay attention as well to the fact that the patterns are similar for intermittent and continuous leaves. So just because somebody is using their FMLA only on an as-needed basis, it's not an indication that they don't have a serious medical condition. So the fact that they're trying to work through it, still show up to work, again, they still have a much higher than average likelihood of ending up in the short-term disability system. So just because you've kept them from going out on FMLA, it doesn't necessarily mean that the problem is solved by its own because they're not taking continuous leave. Now, it's not realistic to expect that even the best wellness program is going to prevent every short-term disability claim. And of course, then the priority becomes reducing the duration, or minimizing the duration, I should say, of the disability when it occurs. And again, our results, they tend to reiterate what we found about the likelihood of short-term disability, that people who are using FMLA before they go out on short-term disability tend to have longer durations, slightly longer durations than somebody who never used the FMLA system. And so, for example, for the most part, when somebody takes a short-term disability claim, in the data that we had, the vast majority also used short-term disability concurrently. And their average timeout was about 46 days. There were some people who used all their FMLA, or we didn't observe any other FMLA use during the claim, maybe 7% of the sample, but the duration of their claims were a little bit longer, so about 9 days longer than the people who didn't use FMLA at all. We saw slightly longer durations if somebody was using intermittent FMLA before they went out on a disability claim, about 2 days longer. And just to kind of get a sense of whether people who use FMLA just have I guess in economic language you would say a utility for long durations. We didn't find it to be the case that if somebody uses intermittent leave after they go out on short-term disability, they didn't tend to have any kind of longer or shorter STD duration. We might have expected a shorter duration if it was the case that some employers are reassuring their workers that you can come back to work and still take time off, job-protected time off on an intermittent basis, and thereby encourage people to come back to work, start getting paid at 100% again. We didn't have a lot of evidence that that was happening, but again, these differences are not really all that great. Now, because FMLA predicts longer short-term disability durations, it's not surprising that it also predicted the likelihood that a short-term disability claim would become a long-term disability claim. I'm not going to go into those results. It'll look very similar to the slides I just showed you, and we go into much more detail in the written report. But again, the running theme of this talk has been that early information about one type of absence or leave can give you an insight into what might happen down the road. And so if you start thinking about different aspects that you can observe about a short-term disability claim, obviously the diagnosis is going to be one of them. And so this is information that case managers can use to assess who might most benefit from disease management programs, if only to avoid costlier long-term disability down the road. So here we have the top 5 short-term disability diagnoses with the greatest likelihood of a later long-term disability claim. So maybe 7% of the STD claims for neoplasms are going to end up in the long-term disability system. About 6% for nervous system and sense organ diseases, on down through circulatory, mental disorders, musculoskeletal disorders. The report has the full list. But you can see that getting information about why somebody is going to be out on short-term disability gives you some insight onto the chance that they're going to end up in the LTD system. Now, I've given you a very, very quick overview of what is contained in the report. The report has many more results than these in much greater detail. One of the things we did with the report, or with the results before we completed the report, was we shared them with who we would consider to be experts in the field of both FMLA and short-term disability management. Experts because they work at companies and they're benefits managers, or they're HR managers or risk managers, or because they are TPAs who help other companies manage these things on their own. We asked them to read the results, to comment on them, to kind of give a sense of what employers can do in light of this information, and to be very clear about some of the obstacles to taking action in light of this information. I'm not going to go into detail about everything that they told us. On the one hand, we talk about that in the report quite extensively, but on the other hand, we are going to have a panel, not the same panel necessarily who told us or who gave us information for the report. We're going to bring them up and ask them to give us the benefit of their own experience and to talk about some of these issues really out there from on the front lines of managing both FMLA and short-term disability.
Thank you, Brian.
Shall we?
Yes. We have our panel of experts. I think I'll just stand up here and let you guys sit down. I've been sitting long enough today. So we've structured this to direct questions to individual people, and then we certainly invite our other panelists to comment as well. And Brian, even though I didn't tell you this, I'm going to ask you a question as well. So let's start with Cheryl. You ready, Cheryl?
I'm ready.
I feel like it's a game show. We should have lights and stuff like that. In preparing for this research, we talked to a lot of employers. We talked to a lot of our members that manage FML. And you keep hearing about what a headache FML is. And so the question really is, how can, and I know you work with lots of employers.
Right.
How can employers see FML as an opportunity as opposed to a headache? How can employers move away from simply focusing on compliance and tracking into strategy of seeing this as an opportunity really to learn something and take action?
Right. And you're right, Tom. We work with a lot of employers and consult with them from an administrator's perspective. And we really see this as an opportunity for productivity, to keep employees at work. Because if you have a well-managed program, so it's not just tracking, it's actually managing that program. And over the years, what we've found is that our clients are asking us for, can you provide us with return on investment, and how can you demonstrate that? We have had many clients. One jumps out at me as a health system that we manage. I think they have about 30,000 employees, and when they outsourced their program from an internally managed, and they knew that they weren't managing it well, to us, they ended up with about a 10-to-1 return on investment, which means that really we were approving the appropriate claims and denying the inappropriate claims. And that's when you start thinking about productivity and the impact for an employer, that whole issue surrounding making sure that you're managing, to your point, not just tracking and looking at that. The data in the report talking about it being an early warning system was really resonated with us. The fact that if we can identify those employees that are going to go out or potentially going to be out from on FMLA, then we can control the duration more effectively, especially if it's integrated with short and long-term disability. That really becomes another opportunity, in addition to utilizing health management and other things. We'll talk about that more as we walk through the thing. It also, as we talk to our clients, it gives us that lens into the organization. So you have FMLA, it's a headache, there's all these things going on. But it can also be a lens into the organization surrounding hiring practices. Are we hiring the right people to do the right jobs? And what can we do to help ensure we're hiring the right people? It gives us a lens into their policies. Is there an opportunity to offer flexible work schedules? Is there an opportunity to think about our business a little bit differently? And then the whole issue of training and educating managers and supervisors. so that from a management supervisor perspective, they really understand more about what FMLA is and isn't, and how they're trying to control it and improve the productivity.
Other comments, Denise? You want to weigh in on your work with employers and how to make this transition?
Did you want me to answer the second question or just support
Just reflect on the first one.
Okay,
We'll go to the
super.
second one in a
Yeah,
minute.
I think that your comment about going upstream, one of the things that employers are trying to do, and we try to support them in doing, is how can you get an early identification of the people who are going to be off work, who need support, who need help, or who need engagement in improving their health. And I think FMLA data can be used that way and can really be looked at as one of the ways an employer has to manage this issue, as well as longer STD and LTD. I think one of the frustrations employers have is, how do I manage FMLA? My hands are tied. Well, there's things you can control and things you can't control. And so this research, I think, gives us a reinforcement to, there are things you can control, you can manage, you just haven't had that piece of information yet, and now we have it to support that.
So let me put our employers on the spot a little bit. FML, headache, opportunity.
A little bit of both. I do believe administratively it puts a high burden on employers, and I think we all want to give our employees the protected time off that they need and deserve, but anything that we have to spend a lot of money and a lot of time trying to administer doesn't make a lot of sense. There's probably an easier way to do it. Opportunity, I see FMLA as kind of a barometer, and if you've got pockets of employees where you have high FMLA, I think it speaks to work environment, other issues, so that is an opportunity.
Okay, thank you. So Denise, what are the barriers, both internal to the employer and external as the employer works with their partners around connecting the dots between family medical leave, STD, and LTD?
Yeah, I think we're still in the phase where fragmentation of the information, the data really hurts us. And I think some of the information in this study is going to support people looking at that FMLA data more and looking at it as an indicator. What we see, I think, is that employers, for instance, don't see the value of it. I work with some employers who do their FMLA in-house, and I think they lose opportunity to manage the whole employee and to manage the whole risk. For instance, one of the ways that FMLA can be a predictor is intermittent leave, and we all know that employers consider that a big headache. Well, if you manage it in-house, you've got maybe an HR person or administrative person who sees what's going on, but it's not connected to anything else. Whereas if you had the data that people are going out for family situations or they had repeated incidences, you'd be able to reach out and get more solutions to the problem for an individual employee. You know, when we look at intermittent leave, it depends upon the statistics you look at. 50 to 80% of it is caused by chronic conditions. So if you're managing it in a silo and you don't have your data connected to other things, like your STD data or even your healthcare data, you could be missing large opportunities to intervene with those employees and get them healthier.
So,
Go ahead.
no, go on, I'm sorry.
Similarly, I think when we have a vendor integration, we see some vendors who will integrate FMLA, STD, and LTD, others who will integrate also workers' comp in their offerings. And I think there's still opportunity for vendors to run alongside the employers and use that integrated data more. You know, when you're looking at an STD claim, how can you go back and see what's been the frequency of FMLA? Do they have a workers' comp claim pending? Not because you want to do this workup on the employee and consider them a bad person or paint a picture of a problem employee, but those are indicators that something's going on with that person. And you may or may not be able to solve it, but it's a good trigger because we're all trying to figure out what's the 20% of claims we need to focus on that are driving the 80% of the results. So I see that more data in the integration. I think the vendors can assist with that as well. The other thing I think was interesting about the study is taking the long perspective, which you talked about, because you know, I've worked on the workers' comp side and the benefits side, and some benefits folks are still thinking about each year in isolation, as you mentioned. And I think this study supports the fact that this is a strategic issue, that if you're going to be doing wellness and prevention in your employee population because you're taking a long view, looking at this issue as well and integrating the information just supports that you need to take the long view with this issue as well. Because as we've all seen the statistic that those 10% of employees who are out each year with an illness or disability are driving 50 to 65% of your employee medical costs. So it all starts to get connected. And the more barriers to connecting the dots, the more you lose valuable information and you lose the synergy you can do from it. Some employers are still kind of doing the simple way in terms of working with their vendors, but we have a lot more early adapter employers who are saying, let's get this all into our data warehouse. I've just started working with a few employers in recommending that they load the FMLA data in because we've had early indications of some of these connections. And is it kind of challenging for the data people? Absolutely. But I think the sooner you start loading it in and really working with it in the data warehouse, the more opportunity you're going to have to see the connections in your own workforce.
Yeah. I think that's a good point. You have a question? Sure, why not?
Thank you. Sorry to interrupt here, but since it's exactly on this subject and because it's a challenge in really taking this on in our own company, with Mass Mutual, I think I said that. When we get this information through short-term disability through our vendor, sharing that information with the vendors who could do something about that is something that's been prevented by our lawyers. So you may have different vendors that do different things. So you're talking about connecting them with wellness programs or with disease management programs. Your health vendor may be providing another sort of program that you may want to put people in touch with. And our lawyers just have had fits about this. So this is a huge challenge, and I'm just wondering how all of you have dealt with that.
Besides firing your lawyers, I think we can turn to the panel. Yeah, and I think that's a very important question. So let's, Maria, you want to address that in your own company about how the legal issues, and then Anita maybe at Safeway?
Absolutely. We use an integrated data warehouse through Human Capital Management Services. It's out of Cheyenne, Dr. Hank Gardner's group. And we put about 43 different data sources in there, all the great medical, disability, absence, engagement, safety, motor vehicle accidents, grievances, you name it, it's in there, performance. And we have them directly contract with the various vendors to send information. So PG&E has no idea who's being sent over for complex case management referrals or counseling on metabolic syndrome. We have them send it and do the business associate agreements and everything directly with those clinical vendors. So we're out of it. We know it's happening, but I couldn't tell you as a PG&E employee who's getting referred over. I just get the aggregate data. So that's one way.
Thank you. Anita, you want to comment on that?
I wish we were that far along the trail. We have very risk-averse legal team who tell our HR people, you can't know anything about the medical condition, and which flies in the face of workers' comp, which we're trying to integrate into the whole process. So it is a problem. Having third-party people manage those issues is really the only logical way to do that. That keeps you out of trouble.
And I think, dealing with the data warehouse issue, and not surprisingly, we feel strongly about integrated longitudinal data at IBI. But think of it this way, if you start to collect FML data, and you start to have health risk data as well, start to look at predictors of FML, because you may find that you're able to take actions, your partners are able to take actions through understanding health risks that might lead you to even reducing the incidence and perhaps the duration of FML claims, not only for employees, but for family members as well. So this notion of integrating data becomes really critical to developing strategy and predictive capability to start to take action before it all happens. Anita, you and I talked a few weeks ago about treating physicians. And you raised the very good point of the role of treating physicians in this discussion. So What are the challenges you face at Safeway and some of the solutions in dealing with treating physicians on managing FML and getting information in a timely way, et cetera?
Well, what you have to know is that I'm a nurse and have been dealing with physicians for my entire career, and most of that in workers' comp. And what's amazing is that physicians are woefully uninformed about benefit structures. They can barely keep up with medical care because it changes so fast. And one of the first things you have to understand is that the physician is in a unique position to set the stage, or at least keep the lights on, around medical conditions and benefits. And unfortunately, they often interpret their position as an advocate, as giving them more treatment, because that's been the prior definition of quality care is more care is better. It keeps them coming into their office, so there's a profit motive involved. They're involved with the entire family, not just an individual like we might see in workers' comp. So the physician is typically the family practice doc asking the employee what he needs. What do you need? You got a broken leg. How much time do you need off? What's your job like? Well, sometimes that matters, and most of the time it's really a matter of how generous are your benefits and how can I help you get those benefits. The other interesting thing about physicians that we're learning, and we're learning this through looking at studies in pharmacy and compliance, is that first, the doctors believe what their patients say. And I'm not saying that doctors are that naive, but they're really put in a position of that's their job, is to believe what the patient tells them, what their patient tells them. So if the patient tells them, I can't do this job with this condition, or my employer is just really awful and this is the only benefit, or this is the only relief I can get, the physician has to believe that the employee, and that's what they do. The other interesting thing is that physicians are just beginning to talk about, not with each other yet, because they don't talk to each other, but talk about, at least in the media, about evidence-based medicine and what are best practices in terms of trying to reduce the unnecessary, inefficient, and duplicative care. And until our physicians have those conversations and start really practicing based on evidence-based medicine, we're going to continue to get some of the decision-making that goes on with physicians. So in our process, we expected to see a small core of physicians making really bad decisions and the other guys doing the right thing in terms of certifying time off. But what we found was across the board, general practitioners didn't know how to do the form, didn't understand that FML was non-paid. They thought it was an extension or a precursor to STD. They didn't even understand the benefit at all. And they really were more concerned about keeping their patient happy than making a good decision. So we needed a third party to go in and talk to that physician and help them understand what the benefit was, how to fill out the form, and also to understand a little bit about the risk that the physician might be creating for his patient by extending and supporting leave rather than return to work.
Thank you. And before we get off the data issue, Brian, so you just don't sit there and, thank you.
Pretty.
So you've now worked with literally hundreds of thousands of data points across this data set. If you gave advice both to employers and their supplier partners about data, what would you tell them about integrating data, the kind of data that are useful? What kind of guidance would you give to those organizations about data?
I would say from the perspective of this study, these data had a lot going for them. First of all, anytime you get data for the same people over multiple years, you're in really good shape, especially when you're adding new hires over time. Secondly, we had them across different programs, so we're able to say, what happens in one area, how does that affect what happens in the other area? And I think they were really well suited to this question, but they won't be really well suited to every question, because as we dug deeper and deeper, we got to these research questions. What happens for the next report on this? Well, we would want to know, how do comorbidities matter? How can we start spotting people who are at risk for an FMLA? These are the kinds of things where only data that are managed, not just integrated, but are managed for the purpose of answering these kinds of questions. These were administrative data. They worked very well, and I'm sure they work extremely well for their administrative purposes. But that's not the same thing as data for answering questions that you were going to have about your own workforce. So again, starting from an integrative perspective, starting from the perspective of we're not collecting data for the sake of collecting data, we want to learn from our data, I think that that's still a leap for a lot of organizations to take, lawyers notwithstanding.
So Maria, PG&E, diverse workforce. What's been your experience in working with different employee populations with regard to FML, and what are some solutions you've employed to try to deal with the FML issue within PG&E?
Yeah, thanks, Tom. I'm going to tell a little story and throw some data in just to make this real for everybody. If it's okay. So this audience is obviously very sophisticated. So would it surprise you if I said the call centers at PG&E had the highest absenteeism?
No.
Okay, so we have several thousand employees across 4 call centers. Just to give you a little context, we are 72% union at PG&E, mostly through the IBEW, International Brotherhood of Electrical Workers, both physical and clerical. And then we have a couple thousand engineering and scientists that are unionized, so about 72%. So we started on this journey before my time at PG&E in 2008, and we tried a lot of the great stuff that you've seen up here. So in 2008, we centralized FMLA so that we'd have all that rich data and we could overlay it. Oh my goodness, let me make sure I get all the points. We tightened up the claims management process. We trained supervisors and team leads so that they would know what they could talk about, encourage attendance. We provided rewards for attendance. We started peer-to-peer physician outreach.
Yes.
We started offering EAP and ergonomic interventions early in the FMLA process. And again, this group, the call center, had 5 times the level of FMLA usage than the rest of the company. And so for the first year that we did all this, we saw I don't have my glasses on, a 4.8% reduction in the absenteeism. And then the second year that we did it, we had a 2.4% reduction. And we felt like we weren't making big strides, even with all of these activities. So we actually sat down with the union for over 6 months and just opened up a dialogue and said, what are the root causes of this stuff? What's really underlying? And the union said, well, we're going to bring in a consultant. He went and did some focus groups, and the employee said, you know, you hired me as a part-time employee. I have kids, and you started pushing mandatory overtime, and I needed to get home to take care of those kids. So I'm going to pull out every protected leave I can to get home to those kids because you broke the employment promise that you made. Or our biggest other group were college students. They were trying to come in and wanted a flexible schedule so they could keep up their and we love those because they're a feeder to some great jobs. We broke our employment promise. We were making them do all this mandatory overtime. So March of last year, we got a new VP in the call center. She came in and said, I'm abolishing all mandatory overtime. We're not doing it anymore. I'm going to hire 10% extra people. We're going to hire full-time people, part-time people. And our absenteeism went down 17% last year. We found one of the root causes. Now we're going to pull that onion back, and we're in these focus groups and working in collaboration with the union. They're telling us little things like, when I'm late for 15 minutes, I might as well just take 2 hours off because I've got to get that time protected in your system. So if I'm sitting in traffic, I'm just going to be 2 hours late because I'm going to have to get the ding anyway. We started a pilot January 6th where we're creating forgiveness for all these little things. You come in 15 minutes late, you can work 15 minutes on the end. We need you there. We need you on the phones. Swapping shifts. We're doing all this flex stuff. So I'll be able to report on our pilot probably by the end of April to see if we've had, but we did all the right things according to the research, but we didn't get to double-digit numbers until we got to root cause.
Great, thank you, Maria.
So,
We talked a lot about FML as early warning. So, Cheryl, I'll address this question to you first, and then Denise as well. How should front-end strategies, EAPs, disease management, ergonomics, how do you bring those in? What are barriers to doing that? What are solutions? How does the employer work with the variety of partners in these different areas? How does this all happen?
Yeah, you know what's interesting is that we've long known that chronic health conditions are early indicators for FMLA. We've always known that. And as we look at our block of business, especially as we're looking at our intermittent leaves, it's even more significant. Okay, so this whole issue of tying everything together on behalf of that employee and all these strategies and programs is so critical in the overall scheme of things. However, the barriers really are we have different touch points for each one of those. We have different workflows. We have different systems that are touching them and vendors, and they don't understand all of that. So those are really the barriers that our clients are dealing with today as we walk through and try to help them with their strategies. So it comes down, there's two options here. You know, you have coordinated strategies, where you have your silos that attempt to work together, or you have fully integrated strategies where you really are tying together the data. Go back to the data. You're tying your systems together and your data together to really have that impact. So let's just take coordination to begin with. In the coordinated programs, you really are looking at a single touch from the employee when they go out. So a single team, single person, single team for that STD and LTD, and then you train them to work with your other partners. So you're from a health manager. This is nothing new or exciting here, but that's really all you have is that training so they know all the tools and resources that are available. You have to do that. We do that for almost every one of our clients today that we work with. So that first touch point when that employee goes out, we can refer them to EAP or we can refer them to health management, whatever the strategy is on behalf of that client. And then try to coordinate that throughout the life of the claim. That early intervention, of course, that clinical piece of that's real important too in that coordination, not just at the beginning but throughout, because those clinical resources that can support them on health management is really important as well. But then if you start thinking about, so that's kind of the coordinated model. That's what most of our clients are doing today, and we support that. Then on the other side, you have the issue of fully integrated programs. So, and there's vendors out there, we're one of them, that have really integrated the not only the infrastructure, so the processes and the workflows, but also the technology and the systems. And with that, then you can really look at all employees. So you have that total population that you're looking at, because most are covered under FMLA or some other type of leave anyway. So you have that total population engagement. And then you're really looking at that early intervention. You talked earlier, and when you kicked off, Tom, about that prevention of claims. We're really trying to drive down not just the time that the employee is out, but that incident level and those incidents that are getting to LTD. We're really looking at that as what we should be focusing on. And when you fully integrate your systems and your technology and your data, then you can have that 360 view of that employee. So it's not just integrating that time that they're out, but having access to their health and pharma data. So that helps you as a case manager, as a person that we're doing that, as we're managing that claim, and when an employee goes out, we have that extra data that we're not going to know about from all their chronic health conditions or whatever else is going for themselves or a family member, and leveraging that family member information as we look at the whole sandwich generation of I'm caring for my parent and now I'm out on a I'm taking intermittent leave because I need to see my therapist. The other thing is when that employee goes out, then it becomes that teachable moment of really taking, and you talk a lot, you've talked for years about those teachable moments, but it really is that teachable moment of really getting that employee re-engaged. So it starts at intake, and so we know whether or not they're engaged, and then from there, we were really looking at that engagement throughout the process, advising and really educating the employee on those other benefits that you as employers have paid for and are trying to provide to your employees. And empowering that employee to be kind of responsible for their health. At the end of the day, the only other thing that we don't hear a lot about in our world, on the disability side of the world, is leveraging incentive programs for positive incentive. So if employees engage and they're doing all the right things, maybe they get a higher benefit than the employee. We talk a lot about incenting employees from a health plan reduction, but not from, if you do all the right things, then if you go out, we know you're doing the right things, and we're going to do what we can do to stand behind you. So those are some of the things that we think about from. Thank you.
And Denise, and then we'll open it up for questions.
Yeah, just a couple comments to support that.
Sure.
I think one of the things that I think is important, and I've seen some research around this, is sustained engagement. And I'll use the example of, a field that's an area that's often overlooked is engaging workers' compensation, employees of workers' compensation injuries in disease management or condition management or EAP. And here's my example from that field, which is, it's common to have workers' compensation employee who works very hard with a rehabilitation person. They finally get them back to work. Okay, fine, they're back to work, boom. What happens is the person who was active in doing their back exercises had gone into some diet things. They get back to work, things are going well. Their Buddha belly starts to regenerate, and they stop doing their back exercises, and you have recidivism. So I think really one of the key ingredients to that is sustained engagement, because those folks that you're interacting with in workers' comp, FMLA, or STD, they're high risk. They had the episode. You have to work with them. So the better we can get at having sustained engagements, how people change their behaviors and still work on that issue once they're back to work and they're feeling better, the better chance we're going to have for reducing recidivism and reducing duration the next time.
Excellent point.
So any final comments in the panel before we open it up for questions?
I would just like to make a comment that when you start down this lonely road to integration, the first thing you're going to find out when you start actually collecting FML and other absence data is your numbers skyrocket. And I got in big trouble when we first started using a call center and calling in our FML, because instead of the numbers going down, they of course went up. And I told them they would, but that wasn't good enough. It took 4 years for us to begin to reduce, and in just one location, we've reduced the FMLA last year, fourth year, the equivalent of 1.5 employees, truck driver type employees. So you have to have your systems in place, you have to have your expectations set, and I agree with everything that everyone said about engaging the unions. First of all, they need to be able to educate their employees. They also need to be able to set the stage for the fact that this benefit is being applied consistently across the board for all employees.
Thank you. So we'll open it up the last couple minutes for questions from the audience before we break. Down here in front. RJ.
Thanks, guys. Nice panel discussion. Cheryl and Denise, I really liked that last point that you guys made, and it's something I've been wanting to do for a year or two, is around the engaging these folks in health management programs. And one of the thoughts I had was, could you tier the short-term disability? I know it doesn't get to some of the predictive nature, but could you tier the pay for those who are engaged in health management efforts? If you're on short-term disability for a health condition, you get 70% if you do nothing, but if you're engaged in a health management program, whether it's disease management or whatever, you're able to get 90%. Have you seen that strategy implemented or worked with employer groups?
I've seen people talk about it, and there are a few employers who are trying to get at it. I think you have to kind of get the right mix, because if you reward people with higher benefits, then can you really get them back to work? I mean, I think there's a lot that goes on there, but I think people are trying to figure out what are carrots, because they do seem to have a better effect long-term than a stick does.
Yeah, and we already know for those employers that have reduction in health plan costs, things like that, that doesn't get 100% engagement either. So, I mean, that just because...
We got 90% on our health screenings. We got 90.
That was excellent.
We let everybody earn to zero deductible if you did your health screening. So, bang, we got it right out of the back. Yeah.
Free always works, okay? So that's what I will say, that free always works.
There are some magic buttons to push.
That's a great point, Maria.
Yeah.
Another question over here.
I'm sort of afraid to stand up because I'm a physician. But
It's all your fault, Tim.
Okay, Anita.
tell you a story and then maybe one recommendation. But so yes, physicians are advocate for patients, and it's difficult trying to practice medicine and trying to figure out what the company benefits are. But by the way, they're only a third of evidence-based guidelines to practice medicine. So most of what medicine practice is actually about experience or consensus. But a lot of this, a lot of issues enter into the medicine practice that are outside of medicine. So, there's a very good program called Preventing Needless Disability, and it's from ACOM. And the author, Jennifer Christian, identified 3 different components to disability. One is whether it's medically related. Second, whether it's discretionary. Could be discretionary of the employee or employer or physician. And the third one was unrelated. And wouldn't you know that most of the things are unrelated to medicine that are keeping people off work. So in communicating with physicians, it's good to be able to talk to the physician. In fact, that whole dialogue, that whole piece was around communications from TPA to companies to physicians. So that if you have better communications with the physicians and ask them to do what they should do, not what they shouldn't do, it actually works, and that's what we do in our company. So I'm an interface between our company's HR and absenteeism. So I filter all this stuff that comes in from HR, bad employee, why is he off on Thursdays? You know, all these things that are incidental to nothing. And then you take it and you try to give the physician, say, doctor, give me the medically related reason this person needs to be off work. And they actually appreciate it. And so I'm able to work with physicians in that manner and probably reduce this nuisance factor of, you know, maybe 10% of the people are the bad actors, but most of the doctors are trying to do their job. And if you just ask them the right questions and say, don't tell me they need to be off because of this or that, you take away the unrelated issues or the family issues, then you can sometimes reduce your disability time off just by communications, by the way you deliver the message.
You know,
so there's no question, comment.
That issue, when you're a health policy researcher, you really want traditional health to be a huge explanatory factor in the outcomes you're interested in. But the fact of the matter is, there are a whole lot of things that affect people's ability, desire to work. Work context, employee engagement, actually we've expanded our research at IBI to include that area, going beyond the traditional health measures into these other measures to give us a better idea from the employer's perspective, what are the things you need to pay attention to if you truly want to maximize the employee's health and their performance at work. So Tim, I appreciate those comments. Any other questions? You really want to go to get a cocktail, don't you? That's all right. Well, I want to thank the panel for participating. Thank you very much.